All right, so today we're going to start with some miscellaneous inflammatory conditions.
Well, if he's a medical student, he wants to sit down.
Sure.
Yeah. Sit down wherever you want.
So we'll start with this case, 54-year-old, shortness of breath and fever. What's abnormal in the chest radiograph? Yeah, so given that history, what would we be considering?
Pneumonia, multiple
Okay.
pneumonia,
Right.
pneumonia, ARDS.
So, well, ARDS does not give you fever typically, right?
Yeah.
Okay. So, besides bacterial pneumonia, what other kinds of infections might give you this appearance?
Viral.
Right. So, what kind of viral pneumonia? Well, these days, of course, we always start with COVID, right? We start with COVID. But is there anything else?
You could consider a typical pneumonia.
This is going around a lot.
Oh, come. Sorry, Dr. Maljan. I just had a test on this.
How'd you do?
5 points above the median, so that's good.
Okay.
94.
All right, so H1N1, but basically viral pneumonia. So when you have bilateral consolidations, viral pneumonia is something to think about. So it can give you a diffuse alveolar damage kind of picture. It can look like ARDS, could be ground glass opacities. Tends to be bilateral, okay, when we have these viral pneumonias, but we do need to consider that. And what if I give you this history? First, what's abnormal on the chest radiograph? Let somebody else have a shot at it. What? Mediastinum what? Yeah, so the mediastinum is white, right? Especially in the right paratracheal regions, here in the right hilum. So what do we think this stuff is? What?
Blood.
Blood?
Right, it's not associated with hemorrhagic.
Yeah, but the stuff that gives you the widening of the mediastinum is what? Lymphadenopathy. So this is going to represent lymphadenopathy. Now, given that history, so this is going to be anthrax. Right? So gram-positive squalene bacteria. Most of the infections that are encountered naturally, though, tend to be cutaneous. But nowadays, of course, anthrax can be weaponized, which means that they make the particles really smaller so they can get into the respiratory tract, travel in there to give people lung infections with this more weaponized form of anthrax. So the spores germinate, the bacteria produces a powerful exotoxin that results in mediastinitis and a hemorrhagic lymphadenitis. So they will develop lymphadenopathy and they can develop hemorrhage within the lymph nodes. So they'll have signs of infection, and then it can progress very rapidly and very severely to shock. So the first finding might be lymphadenopathy because of the affecting the lymph nodes. Right paratracheal here we have hyperlymphadenopathy. Pleural effusions are also common. And then when the patients go on to develop airspace opacities, this to radiate out from the hilum, from the areas of the lymphadenopathy out. And so this high attenuation of the lymph nodes on non-contrast CT can reflect hemorrhage within the lymph nodes. And then pleural effusions, of course, are also common. And then the changes in the lung parenchyma tend to radiate out like this from the hilum, in these cases of anthrax. So you can see rapid progression. Patient gets intubated. You see the lymphadenopathy here, the pleural effusions, but there's rapid progression as far as the lung changes. Here there's actually hemothorax, so bleeding there into the pleural space. So adenopathy, hemorrhagic effusions, pericardial opacities, those are the radiologic findings associated with anthrax. You can't see lymph nodes, we might see that also associated with anthrax.
In that case, would you also consider, like without a history, like meds or something? Right?
Sure. I mean, you know, there's a differential for enhancing those, and we're gonna get into that a little bit later. Okay? And then here, with delayed imaging, you can see the peripheral enhancement even better sometimes of these hemorrhagic nodes. So the internal areas don't enhance as much, but the periphery will enhance a little bit more. So I give you this chest radiograph, chest pain and fever. You should be able to arrive at a specific diagnosis in this particular case if you put the findings together. So what are the findings on the chest radiograph? Yeah, so we have some hazy opacity up here, maybe a little bit down here, over here, right? What's that? He has a central light here. So septic emboli, certainly something you might consider, although these don't look really nodular. These look more like ground glass opacities or consolidations.
Multifocal, like atypical pneumonia.
So atypical pneumonia, certainly pneumonias, or atypical pneumonia is something you would consider. But there's another finding on the chest radiograph. And it's important to be able to notice these things because often the ER is very remiss about giving you the history. So you might wonder about lymphadenopathy here, right? There's this extra bump, right? So that certainly might be lymphadenopathy. What do you think of the bones?
Oh,
Oh.
Chest syndrome.
H-shaped vertebrae.
Yeah, you have these H-shaped vertebrae. So this patient has an underlying sickle cell disease, right? Like I said, often the ER may not give you that history, so you have to be able to pick up some of the findings associated with sickle cell disease yourself. Right? So then this would be acute chest syndrome from sickle cell disease. So that accounts for 25% of hospital admissions, fever, chest pain, leukocytosis, new consolidations on the chest radiograph. So some theories about this: pulmonary infarcts or vaso-occlusive disease from microvascular occlusion by the sickled red blood cells, resulting in ischemic tissue injury and infarction, or it can also be set off by pulmonary infections. So the infection itself can also set off a sickling crisis in these patients. And that's more common in younger patients. So when you get sickling of cells, increased blood viscosity, decreased tissue perfusion, acidosis, more sickling of cells, so it's a vicious cycle when the sickling of cells develops in these patients with acute chest syndrome. Consolidations, cardiomegaly, enlarged pulmonary vessels, bony changes of sickle cell disease, infarcts, H-shaped vertebra, right? These are things that you want to notice on the chest radiographs. And ground glass opacities here, hypoperfusion, we might see that as a result of the sickling. Some hypoperfusion there within the lungs also. There's a pneumonia in this case. And then, very characteristic of sickle cell, the H-shaped vertebra from the avascular necrosis of the end plates. And here that is on CT. H-shaped vertebra. Now here's a patient with sickle cell disease. So, any finding on the chest radiograph? Yeah, so looks like there is some cardiomegaly. Anything else?
There is a paravertebral,
What side? Well, you said paravertebral, so
Yeah.
what side?
the right side.
Okay. So here on the left side, this is the aorta. What is this on the right side? Esophagus, dilated esophagus, is that filled
Extramedullary.
with sickle cell?
Extramedullary.
So here's the CAT scan. So first, what are the findings associated with sickle cell in the CAT scan? So what findings are associated with sickle cell in the CAT scan?
There's a soft tissue.
Well, before we get to that, what are the other findings associated with sickle cell?
The spleen.
pores. I mean,
Calcification.
So this is autosplenectomy anemia, right? Small calcified spleen. The heart you guys said the heart was big, right? It's a big heart. And then now we get to this right paravertebral mass, right? And so with sickle cell, we notice also that it has some elements of fat in it, right? So this will be extramedullary hematopoiesis, right? The patient with sickle cell. Extramedullary hematopoiesis. Interestingly, on one coronal image, you can make the diagnosis. Here's your autoinfarcted spleen, there's your extramedullary hematopoiesis, you have the bony changes. Look at the infarct here, the uterus, right? So you want to be able to pick up the changes of sickle cell, because again, you might not get that history when you are reviewing the images, the CT scan. So this patient has a chronic cough. The finding is that normal?
maybe raise vascular mass.
Yeah. It's a kind of opacity down here, right? So we think this might be
Chronic cough? Could be analysis,
could be pneumonia.
could be pneumonia.
Oh, that was our sickle cell case. So here's the CT. So what do we have?
Right, middle and lower lobe, attenuating.
So right middle lobe, right lower lobe, we have some consolidations, right? Also in the left lower lobe, and you said something about the attenuation. Yeah, it's fatty attenuation. So the diagnosis is what?
Lipoid.
It's lipoid pneumonia, right? So, how do people get lipoid pneumonia?
Aspiration of oils.
Yeah, usually aspiration of mineral oil. Right? So this is lipoid pneumonia. That's the appearance of lipoid pneumonia. Fatty attenuation consolidation. That's diagnostic for lipoid pneumonia. So when we have something that looks like a spiculated mass, right? It's got fatty attenuation in it as a complication of lipoid pneumonia. There's a term for this. Do you know what that term is? Mass from lipoid pneumonia. It's called a paraphenoma. That is a paraphenoma. Okay? So lipoid pneumonia, usually aspiration of oil, typically elderly patients with constipation or esophageal disease, reflux achalasia, they take mineral oil, and then they aspirate that into the lungs. Paraphenoma. Paraphenoma. Okay. And they develop these chronic consolidations of lipoid pneumonia. Macrophages phagocytose the oil, resulting in infiltrate consistent of lipid-laden macrophages on path. So please realize you are getting radiologic pathologic correlation in this conference. Make a note of that. Paraphenoma, stellate tumor from fibrous tissue surrounding the fatty consolidation. Okay. So they might look ominous, they might look like tumors, but if you notice the fat, the fatty attenuation, then we can say it's lipoid pneumonia, and it is benign. These tend to be chronic, and sometimes can resemble masses. Okay, 42-year-old man, HIV positive. There's pneumonia there in the left lower lobe. What's the most common cause of pneumonia in HIV positive patients? So it's just community-acquired pneumonia, it's still the most common type of pneumonia. Okay? Patients are HIV positive. So So here we'll talk about now, we'll discuss some pulmonary diseases that we can see in patients with AIDS and HIV. One of the most important things when you're approaching the differential diagnosis is knowing what the CD4 count is, because that does affect what you would be considering. So when the CD4 count gets below 200, then we think of AIDS. So bacterial pneumonias, we can see above that cutoff of 200. With tuberculosis, we talk about the apical fibrotic disease. We tend to see that above the 200. Below 200, then you tend to get more lymphadenopathy with tuberculosis. And then with atypical mycobacterial infection, you're also susceptible to that with the lower CD4 counts. Then you can get into pneumocystis, fungal infections, Kaposi's, and then all these other things associated with the lower CD4 counts. So the CD4 counts can help you to formulate your differential diagnosis when you're looking at or interpreting studies on patients who are HIV positive. So the community-acquired pneumonias can occur at any level, but usually, especially if the CD4 count is greater than 200, they're 4 times more likely to develop bacterial pneumonia than the general population, and the most common organisms are, strep again is still the most common. They can be multifocal in patients who are HIV positive. They might be more aggressive in these patients in terms of the pneumonias that we can see. More likely to be multilobar. You can see the progression, the rapid progression in this particular case. So it started out like this, and it looks like this just 2 days later. Here's a case of Pseudomonas with cavitation. HIV positive, fever. We look at the chest radiograph. You notice anything? So we can close the door. So findings are quite kind of vague here, right? You're questioning what, Jose?
Like cavitation
Where?
right upper lung and
Up here?
yeah, and maybe the left upper like perihilar.
Here?
Yeah, that one.
Okay. So what's the answer?
Okay, septic emboli.
Yeah, so this is septic emboli. So this is also very typical in patients who are HIV positive. They can present to the emergency room with signs of infection. The chest radiograph, not very revealing, or the findings at least very difficult to interpret. Very easy to, so that's why your threshold for doing CT on these patients should be very low. Even if the chest radiograph looks normal, the CTs can be, very quite revealing. What test do we recommend next in this patient?
Echo?
Yeah, echocardiography in somebody with septic emboli. We're looking for evidence of endocarditis. Okay. HIV positive. How's that going on in chest radiograph?
Molecular opacities, only 86.
So ill-defined opacities up here. Yeah, that's true. Anything else?
The mediastinal?
Yeah, what's wrong with the mediastinum? The mediastinum looks kind of wide, so you interpret that as
Maybe lymphadenopathy?
lymphadenopathy. So here's the CT on this case. What are the findings on the CT?
What if mediastinal lymphadenopathy?
Yeah, so we see now the reason for the wide mediastinum. We can see all of this mediastinal lymphadenopathy. We saw on the chest radiograph there was some ill-defined opacities, right? Especially there in the left upper lobe. Here on the CT we see what?
The centrilobular
No, I would say random.
or random? Yeah, I think it's random. There's like little place.
Yeah, so we see some of these nodules. So what do we think might be going on in this patient?
Could be like biliary,
Biliary what?
TB.
TB, right?
Yes.
Also,
The lymph nodes? No.
would the lymph nodes be consistent with TB or not?
No, not like that. Could you have like lymphoma?
Another patient, 46-year-old HIV positive. What do we see on this CT?
Exotic.
So what is this patient have? This is tuberculosis, same as this
I
one.
was sent this.
So lymphadenopathy from tuberculosis and also from atypical mycobacterial infection, very common in patients who are HIV positive. So it belongs in your differential diagnosis for lymphadenopathy in these patients. Here we've given contrast, and you can see that characteristic appearance of the low attenuation nose with the peripheral enhancement. Okay? So when the CD4 count is greater than 200, we get that immunocompetent pattern of upper lobe fibronodular disease. CD4 count less than 200, you get an immunocompromised pattern where we get more lymphadenopathy, and you can also have more lung disease. Low attenuation nose can be very characteristic of tuberculosis. So the upper lobe fibrocavitary disease is associated with the immunocompetent state, but if we see lymphadenopathy, there's right paratracheal and right hilar lymphadenopathy. And then this characteristic low attenuation nose with peripheral enhancement is very typical of tuberculosis. Atypical mycobacterial infection can look very much the same also in these patients. This is associated with lower CD4 counts. They might also have low attenuation lymph nodes, although that's more typical of TB, but it can occur with MAI. So they can have lymphadenopathy. It can also have lymphadenopathy elsewhere also. It doesn't have to be within the chest. So TB and atypical mycobacteria can be your differential diagnosis in patients who have lymphadenopathy who are HIV positive. So here's a patient with atypical mycobacterial infection before antiretroviral therapy. That's what the mediastinum looked like. And 1 month after antiretroviral therapy, this is what happens to the mediastinum. So why do we have this change? What's going on?
The immune reconstitution.
Yeah, even if the patient is being properly treated, right? So immune reconstitution syndrome can occur with antiretroviral therapy. So the lymphadenopathy can get worse, right? So you can see lymphadenopathy here that gets worse on these patients after starting antiretroviral therapy. So it's immune restoration syndrome. It's a transient clinical worsening of chest radiographs in these patients. So it's due to the improved immune function from the antiretroviral therapy. Interestingly, they can also manifest sarcoid. That is also associated with this immune restoration syndrome. So as their immunologic function improves, then they can manifest lymphadenopathy as a consequence of that. Okay? So patient with TB, after starting antiretroviral therapy, it looks like it's worsening of disease there within the chest, this patient, even though they're also being treated for tuberculosis. Patient who's HIV positive, and what's abnormal on the chest radiograph? Yeah, so hazy opacities bilaterally, so somebody is concerned about pneumocystis, right? And the hallmark of that on CT is ground glass, right, ground glass opacity. So if we have ground glass opacity consolidations, we worry about pneumocystis. Now sometimes you may have a patient who's short of breath in the emergency room, they get a CT scan, PE scan, right? And you notice these ground glass opacities on your PE scan. You might think it's pulmonary edema, look for interlobular septal thickening, pleural effusions, etc. But if you see this in a young patient, they may not have done an HIV test yet, right? So you might be the first one to suggest that maybe this patient has pneumocystis pneumonia, and that they should test the patient for HIV. Now, another hallmark of pneumocystis is, so these are, what are these? These are called pneumatoceles. Yeah. So these are pneumatoceles. So these can also occur in these patients. So because of damage to the lung, you get dissection of air into the interstitium, and they develop these round air cysts within the lung parenchyma, in addition to the ground glass consolidations. Okay? Now these can resolve over time. That can get better over time. Okay? So that's pneumocystis pneumonia. I'm sure we're very familiar with it. It can present with shortness of breath and hypoxia. Again, this is associated with low CD4 counts. And we recognize it from the ground glass opacities, and might also see the lattices on the CT scan. So the findings can be subtle. You may not see anything on the chest radiograph. That's why, again, for these patients, you should have a low threshold for doing CT, and then that's when you'll pick up the ground glass opacities representing the consolidations from pneumocystis. Now, when the patients develop these pneumatoceles, they're at risk for barotrauma, so they can develop pneumothoraces as a result of that, and that can be very hard to treat because they can get massive air leaks. And so even when they treat them with chest tubes and everything, they can be very refractory to treatment. So this is a complication also of pneumocystis infection when these patients form pneumatoceles, these large air leaks. So another patient who's HIV positive, anything abnormal on the chest radiograph?
Hazy/maybe like little minor opacities on the back.
So on the left side, some hazy opacity. What do you think that is?
What do I think that is? I mean,
This hazy opacity here?
oh, like from the
Sure.
future.
I mean, you don't see the costophrenic ganglion, so you might wonder about a pleural effusion. But you also mentioned nodular opacities, right?
Mhm.
Big nodules or small nodules?
Small?
Small nodules.
Yeah.
So what are you thinking about?
HIV positive micronodular.
HIV positive micronodular pattern, you might consider what? Sure, miliary tuberculosis, right? Micronodular pattern in persons who's HIV. But in addition to TB, they're also susceptible to fungal infections. So cryptococcus is a common infection that these patients can also get. So that can also give them this miliary appearance, also associated with low CD4 counts, and a complication of that is cryptococcal meningitis. So realize that TB is not the only thing that can give these patients a miliary pattern, a miliary disease. So this is cryptococcus forming an abscess in this particular patient who's HIV positive. Aspergillosis can also affect these patients. They can have tissue invasive or invasive aspergillosis. So we've talked about aspergillosis before. So that can occur. Patients who are HIV positive, it can give them cavitary lesions. It can also affect the airways. They can develop airway invasive aspergillosis, where you get infection that involves the trachea and also the very small airways, kind of tree and bud nodular opacities there, which would be very small airways. So airway invasive aspergillosis can also occur in patients who are HIV positive. Other infections associated with low CD4 count CMV, that gives you a nonspecific appearance of diffuse ground glass opacity, can be often mistaken for pneumocystis, but difficult to diagnose as it requires CMV recovered by culture, CMV inclusion bodies, progressive pneumonia that responds to antiviral therapy. So it's a difficult diagnosis to make. Many times the patients are also super infected with CMV in addition to whatever other infection that they might have. But this can also give you ground glass consolidations. Then there's bacillary angiomatosis, or cat scratch fever. So from exposure to cats, fleas, lice. So this can also affect patients who are HIV positive. It can give them skin lesions that mimic Kaposi's, so it can be mistaken for Kaposi's. They can have endobronchial lesions, they can have lymphadenopathy, they can have effusions. So consider that infection in patients with lesions resembling Kaposi's sarcoma. So they can develop nodules also, all kinds of other changes. Lymphadenopathy can also occur in these patients. So there is a very strange appearance in somebody who's HIV positive. So what are the findings here? Yeah, so we have interlobular septal thickening. What else? Yeah, you have these nodular opacities, these scattered nodular opacities. Anything else?
Thinking of the
Yeah, there's parabronchial thickening, right? So there's parabronchial soft tissues also appear thicker, okay? So certainly pulmonary edema, whenever you see interlobular septal thickening, is something that you would consider. But given that you have these nodular opacities, what else would you think about?
Kaposi?
Yeah, Kaposi sarcoma, right, is another thing to consider in these patients. That's also associated with low CD4 count, so that's associated with these viruses. And if we're thinking about it in the lungs, you can ask the question, do they have skin lesions? Because 90% of those with pulmonary involvement will have skin lesions. So you can ask the clinicians about that. So some of the manifestations on imaging tends to give you this thickening of the perihilar tissues. And so you have these kind of, these perihilar opacities, parabronchial thickening, ill-defined nodular opacities that you might also see. There's a catchphrase that's used for the appearance of the lesions that you might see within the lung parenchyma. And they have those ill-defined edges. Do you know what the term is?
Inside.
Flame-shaped lesions, yeah. Flame-shaped lesions. Right? So these irregular edges kind of look like, I guess, flames. So they're called flame-shaped lesions.
Of course that
Looks like a what?
like a plane.
Flame.
Flame.
Like fire,
Oh,
flame.
okay.
Flame. Or a plane on fire, I mean. That's a different discussion. All right. HIV positive, the finding here. Yeah, so you have masses here on the left side, right? So you have masses. Now, of course, any of the infections that we've talked about might give you masses like fungal infections, tuberculosis, etc. We've touched on neoplasms, right? So Kaposi's would also be a differential diagnosis. But what other neoplasm would be your differential diagnosis for masses in a patient who's HIV positive? What kind of lymphoma? Well, you have two choices. Non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma. So that is also a common neoplasm that can occur in these patients, and that can present as lung lesions, as parenchymal masses, sometimes without lymphadenopathy. So they don't have to have lymphadenopathy. So AIDS-related lymphoma is associated with low CD4 count, usually highly aggressive B-cell lymphoma. They don't have to have lymphadenopathy, can't present as nodules, they can have cavitation. Okay? So it's important to consider this. Now, patients with AIDS, they can also develop lung cancers. There's some controversy whether or not they're at increased risk for lung cancer, but what is true is that the lung cancers, if they get them, tend to be very aggressive. So if they have lung cancer, it tends to be very aggressive lung cancer in these patients with AIDS or HIV. 12-year-old HIV positive, here on the chest radiograph, we see what? Yeah, again, we see small nodules, right? And again, if you have a micronodular pattern, if somebody who's HIV positive, your first thought would be what? Sure, miliary infection, miliary TB, miliary fungal infection, right? Now, in addition to the nodules, the CT here also demonstrates another finding. What's the other finding? Yeah, you see these cysts, right? So now, HIV positive with nodules and cysts, if you put that together, you come up with the answer. Especially the 12-year-old young patient, HIV positive, young patient HIV. In this age group, it's actually, it's an AIDS-defining illness in these patients. LIP, lymphocytic interstitial pneumonitis. Okay. So lymphocytic interstitial pneumonitis can also affect patients who are HIV positive, and that can manifest as nodules with cysts, with these cysts. So there are various lymphoproliferative disorders of the lung that can be seen with HIV. LIP is the most common of those. But there are other types of lymphoproliferative disorders. So LIP is when you get infiltration of the interstitium by mature polyclonal lymphocytes, more common in children than adults. It tends not to progress to lymphoma. So you have polyclonal lymphocytes here in the interstitium as opposed to monoclonal lymphocytes, which is what you see with lymphoma. Again, note the radiologic pathologic correlation. So there's a wide variety in terms of how this can manifest in imaging, reticular nodular opacities, mixed opacities, nodules, right, ground glass opacities. The cysts don't tend to be specific if you see cysts. So think about LIP if you see cystic lesions. So with LIP, nodules, cysts. So the nodules can also be peribronchial vascular. The cysts may represent bronchiolitis or air trapping as a result of bronchial obstruction from the infiltration of the interstitium around the airways. Now there are other lymphoproliferative disorders also, we won't get into those, but just keep LIP in the back of your mind when you're dealing with patients who are HIV positive. Here's an example of non-specific interstitial pneumonitis. You can have all kinds of these strange interstitial changes that these patients can get. So this patient's HIV positive. The finding on the imaging here is what?
Enhancing lymph nodes.
Yeah, so there's enhancing lymph nodes, right?
Castle
So patients, well, you give me a differential of enhancing lymph nodes in patients who are HIV positive. There are three things that you can talk about. You mentioned one, which is Castle. What are the other two?
Is it Kaposi?
Yeah, Kaposi's is another one, and
Lymphoma?
no, we touched on it earlier. It can resemble Kaposi's. Bacillary
bacillary
angiomatosis. Right. So those can give you enhancing lymph nodes if patients are HIV positive. Right? Enhancing lymph nodes. So multicentric Castleman's disease, Kaposi's, bacillary angiomatosis. These can give you enhancing lymph nodes in patients with AIDS. Okay? So multicentric Castleman's disease, it's another lymphoproliferative disorder. CD4 count is usually less than 350. Enhancing lymph nodes. They may also have peribronchial vascular nodules, but the enhancing lymph nodes is the most characteristic finding for Castleman's disease. There's another patient who's HIV positive. The finding here is you sure that's lymphadenopathy? So where's the abnormal opacity?
And the AP window?
There's this big thing over here, right? What is that big thing? Well, if you look at the lateral view, does it help you?
No.
Do you see a donut?
You do not see it.
You do not see a donut, right? This part is still relatively clear. If this were lymphadenopathy, you would expect to see donut. Instead, you have all of these dilated vascular structures. So what are we looking at here? Yeah, there's marked enlargement here of the pulmonary arteries, the central pulmonary arteries. So this patient has what? Pulmonary hypertension. Yeah. That can also be associated with HIV. These patients can develop pulmonary hypertension. Okay. So large pulmonary artery in these patients can be a manifestation of pulmonary hypertension. Small percentage of patients with AIDS not related to length of disease, viral load, or CD4 count. So it is something to consider if you have big pulmonary arteries in these patients. Pulmonary artery hypertension. The other findings, big right atrium, big right ventricle, right ventricular hypertrophy. Of course, all of that goes with the PA hypertension. 22-year-old man, HIV positive. T2-weighted images. What's the finding?
Okay, so we have like multi-weighted
What?
fluid-filled
Yeah, so what do you call these? Well, you said they're fluid filled, so what do you call them? Cysts? Where are they?
In the anterior, mediastinum.
So what does this patient have? Multilocular thymic cysts. So this is also associated with HIV. These patients can develop these large cystic lesions within the thymus. So they resemble lymphoepithelial cysts in the parotid gland, septated multilocular cystic masses in the intermedius multilocular thymic cyst. Okay. All right.